Restrepo. He completed his medical school at Pontificia Bolivariana University in Medellin, Colombia in 2000. He then completed a residency in internal medicine at Thomas Jefferson University in 2013. After his fellowship, Dr. Restrepo completed a master's in basic science at Jefferson Graduate School of Biomedical Sciences and a clinical and research fellowship in pulmonary vascular disease at the University of Pennsylvania. Dr. Restrepo is currently an associate professor in the Department of Internal Medicine and the associate division director of pulmonary critical care and sleep medicine at USF. He has participated actively in clinical research in our division in over 7 clinical trials and several others under the pipeline, looking at novel drug therapies for pulmonary hypertension and pulmonary vascular diseases. Dr. Restrepo was one of the pillars of a groundbreaking study published in the New England Journal of Medicine in 2021, showing the positive effects of inhaled treprostinil in patients with pulmonary hypertension due to interstitial lung disease. He has published over 10 peer-reviewed journals and has been invited as a speaker in over 20 international conferences. Please welcome Dr. Restrepo, and allow me to welcome Dr. Restrepo into Medicine Grand Rounds and enjoy his talk. Thank you.
Thank you, Dr. Eraso, for the introduction, and thank you to the Internal Medicine Department for the invitation to give this lecture. And when I was proposed to give this talk, I really wanted to try to cover what is new in pulmonary arterial hypertension, because as you probably are aware, there has been huge change and a huge drift in terms of therapeutics and how do we follow up these patients in our clinics. Here you have the list of my disclosures as a consultant, speaker, and research funding. And this is how the future looks for pulmonary hypertension. The way as I describe is I think we are on the golden years for the patients on pulmonary hypertension. I can't spend 1 hour talking about each of these pathways that right now are on the pipeline to try to produce new molecules and new therapeutic options for these patients. If you remember, pulmonary hypertension was a condition, a disease that back in the 90s was a death of sentence. Those patients were having survivals of 6 months when they were progressing to worse functional classes. After 25 years of research and trying to investigate, we have improved that survival dramatically, and I'm going to talk a little bit about that a little bit later. What I want to accomplish with this conversation today is probably understand the new definition of pulmonary arterial hypertension. It has changed dramatically on the last 5 years, actually. Go over a little bit of the current classification system, which is pretty much what we used to know on the different groups of the pH. Understand how the line of management can be a little bit different for the different types of pulmonary hypertension, and how do we guide our therapy now in 2022. How the studies have changed, how the approach and the look of these patients have been a little bit different now, the way how we approach them. And maybe a little bit later, touch a little bit about the new kids on the block, because besides the traditional therapeutics that we have had for, 20 years now, we have few players in the pipeline that we're probably going to start to use very soon. So up to 3 weeks ago, this was the new definition of pulmonary arterial hypertension. This was from the proceedings of the 6th World Symposium on Pulmonary Hypertension. This meeting, all the big experts get together every 5 years. The first one was back in 1973 to try to define what is pulmonary hypertension and try to define the guidelines to treat these patients. And traditionally, before 2018, the mean pulmonary pressure was defined as 25 to call a patient to have pulmonary arterial hypertension. That was changed to 20 because there is good evidence now that the absolute normal mean pulmonary pressure is 14 with a standard deviation of 3.3. So when you add the two standard deviation for normality, the absolute number to define pulmonary hypertension was dropped to 20. The big problem with this is none of the study that has been done so far included these patients on this category. All the studies that have been done for pulmonary hypertension therapeutics have been done with a threshold of 25. We must have a left-sided pressure absolutely normal, less than 15. There is a lot of argument on the scientific community that even 15 is a very conservative number, because some people consider that 12 should be the consideration for pressures coming from the left side of the heart. And as part of the definition was included a pulmonary vascular resistance more than 3. If you guys remember, pulmonary resistance is calculated based on the difference between the mean pulmonary pressure minus the wedge divided the cardiac output. And that's to account those patients where the cardiac output might be elevated, and the consequence on the elevation of that mean pulmonary artery is a reflection of that increased flow through the pulmonary vascular bed. But as I said, that things are changing dramatically. 3 weeks ago, we came up, or at least the European groups came up with a new definition, a new change, and this is what they are proposing to as a new definition for pulmonary hypertension. I have to disclose that this has not been validated or taken by everyone yet. It was just published at the European Heart Journal by the European Respiratory Society. But they are trying to come up with a instead of calling it pulmonary arterial hypertension, they are trying to call it pre-capillary pulmonary hypertension, where the disease is primarily in the pulmonary vascular bed. And they drop that pulmonary vascular resistance to 2. The reason for this is there are few prospective studies and a bunch of retrospective studies, and actually a couple of meta-analyses where they showed that patients with pulmonary vascular resistance between 2.1 to 2.9 and mean pulmonary pressures between 21 and 24, so those patients who are we used to consider intermediate, those patients have relative risk of dying, odds risk of dying at 5 years between 1.6 to 1.7 between all the literature. So they have an increased incidence of mortality associated to cardiovascular events. And that's why they are proposing to drop the pulmonary vascular resistance to 2. They also define that all the pulmonary hypertension patients, they must have a mean pulmonary pressure of 20, right? But then we need to have a good definition to see who is a pre-capillary pulmonary hypertension when they have a normal wedge and an elevated PVR. What the pulmonary venous hypertension, the one that is related to the left heart disease, we are proposing to call it now isolated post-capillary pulmonary hypertension. And those are the patients who still have an elevated mean pressure more than 20, but a wedge also is elevated more than 15, to evidence that those pressures are being transmitted from the left heart, and they're going to have a normal PVR with less than 2. The combined pulmonary hypertension, combined pre-capillary and post-capillary, are those patients who have an elevation of the mean pulmonary pressures more than 20, pulmonary wedge more than 15, and pulmonary vascular resistance also elevated more than 2. This is a very tricky group because we have a lot of these patients, and it seems like that vascular bed in the pulmonary arteries, when it's exposed to such a chronic transmitted pressures from the left heart, they start to develop the same physiopathologic changes than the patients with the pre-capillary pulmonary hypertension. The problem is, up to today, there is not really a study to document any therapeutic options for these type of patients, and they actually are the most common group. Once more, they are talking about exercise pulmonary hypertension. Every human being is going to increase pulmonary pressures when they do exercise, probably secondary to increase in the cardiac output. The problem is some patients are going to elevate those pulmonary pressures out of proportion to that increase in the cardiac output. Somebody that I remember, somebody who was my mentor was Dr. Rombach, that everyone remember him. He was one type of doctor that he will do exercise on every single patient on the cardiac cath. And he will be one of the doctors of the group that he will treat patients with exercise-induced pulmonary hypertension. Whenever we go to these meetings, there is a huge conflict and discussions because we don't have any evidence if these patients need to be treated. We don't have any evidence of the outcome of treating those patients or not treating these patients, but they just want to release on these new guidelines that when you see those elevations in the mean pulmonary pressures out of proportion to that increase in the cardiac output, we need to put attention to these patients, and then probably excellent centers can define if the patients need to be treated or no, with the help of other diagnostic modalities, including cardiopulmonary exercise test, exercise-induced echocardiograms, and things like that. Now, the pathogenesis of pulmonary hypertension is still the same. We have learned a lot of things about that, but we know that you need a genetic predisposition. We have been able to identify few mutations on genes that can be transmitted in families, and that's the base of what we call hereditary pulmonary arterial hypertension, but we know the patients need to have a genetic predisposition that associated to other risk factors, and you can call these risk factors as lupus, all the inflammatory markers related to connective tissue disease of lupus, scleroderma, rheumatoid arthritis. You can call these other risk factors as a liver disease, all the neovasculature stimulus that happen on chronic liver disease. Call it smoking on patients with COPD, or the inflammatory markers associated with interstitial lung disease, but you need an extra risk factor to develop pulmonary arterial hypertension associated to that genetic predisposition, and that is going to produce all the alteration of the pathways and mediators, where the vasoconstriction is going to be the primary stimulus, and I'm going to go over a little bit on the pathways that we know so far. Now, all of that and all that inflammation is going to produce a proliferation of all the layers on that pulmonary vascular bed. There is going to be an increase of thrombosis in situ, and all of that is going to produce the vascular remodeling that associated to that vasoconstriction is what is going to increase the vascular resistance in the cardiopulmonary system. Now, let's talk a little bit about the classification. The classification is a little bit of what we are used to it. When the disease is primarily on the pulmonary vascular bed, we call it pulmonary arterial hypertension, or what we are trying to call pre-capillary pulmonary hypertension. Within this group is what we know as idiopathic. That is not the most common group anymore. On this group 1, heritable, when we have the families of first degree, and when we are able to prove a mutation on one of the few genes that we have identified. Drug and toxins induced pulmonary hypertension used to be the more prevalent, the fen-phen type of medications that the patients used to use to lose weight back in the 90s and the 2000s. Now, cocaine and amphetamines are the main one associated to as a drug and toxins induced. And then the pulmonary hypertension associated with other conditions. The most important thing here is the connective tissue diseases. HIV infections continue to be an important source of patients with pulmonary hypertension secondary to another conditions. Portal hypertension is pretty important for us because we have a huge liver transplant service, and we see a good amount of these patients with portal hypertension and pulmonary arterial hypertension. Congenital heart disease and schistosomiasis. This parasite that is so prevalent in South America, Asia, and Africa is actually the most common cause of secondary pulmonary hypertension worldwide when we account to all the cases out of the United States. There is a particular group, the 1.5 and 1.6 there in the slide, that is very small in terms of prevalence, but it's so important because it's those patients who were responders. And I'm going to explain this a little bit later, but they are responders to vasodilator challenge when we do the cath, and those are the patients who respond to calcium channel blockers. It's a very small percentage of those, but still we see those patients that we put them on calcium channel blockers, and they have an amazing response, and the disease never seems to progress. The group 2 pulmonary hypertension or isolated post-capillary is secondary to left heart disease. You can call it heart failure with reduced ejection fraction or preserved ejection fraction or diastolic dysfunction, valvular heart disease, or any congenital or acquired cardiovascular condition leading to pulmonary hypertension. The group 3, secondary to lung disease or hypoxia, including obstructive lung disease, restrictive lung disease, combination of those two patterns, hypoxic conditions without lung disease, for example, those patients that live in high altitude, more than 2,500 meters. So cities like Quito, Bogota in Colombia, La Paz in Bolivia, even Colorado, some of the Colorado cities have a little bit of higher incidence and prevalence of pulmonary arterial hypertension and is think to be related to the hypoxia without that lung disease. This is a particularly important group, as I'm going to say a little bit later, because for the first time, we are doing studies on this group of diseases. Excuse me. And we are now have actually availability of therapeutics for this type of patients. The group 4, pulmonary hypertension or secondary to artery obstructions, used to be called only chronic thromboembolic pulmonary hypertension, but now they're realizing that it's more other conditions that can produce obstruction on those pulmonary arteries. But again, chronic thromboembolic disease continue to be the leading cause of this group of pulmonary hypertension. The big importance of this group is we have a surgical option, and most of the time in a expertise center, those patients are able to be weaned from medications and from oxygen. We don't talk about a curative surgery because we don't know a long-term yet what is going to happen with these patients, but at least in the post-surgical proximity, they are able to be weaned from medications, most of the patients, and most of the patients also are able to be weaned from oxygen. And the group 5 is the group with unclear or multifactorial mechanisms. Sarcoidosis is there regardless of the presence of lung disease or no, metabolic disorders, anemias and sickle cell anemia, who used to belong to the group 1, now is placed on the group 5, just because we don't know many deep knowledge about these conditions. And this is the kind of group that we just don't know yet what to do with them. But remember that not all the pulmonary hypertension is pulmonary arterial hypertension. Pulmonary hypertension secondary to left heart disease continue to be the leading cause of all the patients coming with a suspicion of pulmonary hypertension. This study is a little bit old, but it still applies to date. This study, they account for 160,000 echocardiographies, and about 10% of those had an estimated pressure more than 40. Only out of those patients, 2.3% were diagnosed with pulmonary arterial hypertension after full evaluation. Big percentage, almost 80% of those patients were diagnosed with group 2 pulmonary hypertension. And that's why I want to bring here, when we do echocardiogram, which is the best test to screen for patients for pulmonary arterial hypertension or pulmonary hypertension, we need to analyze more than the estimated number that our cardiologists give us. We have now a recommendation that was done back in 2015 and also reinstituted on the recent recommendations that if the patient has an increased peak tricuspid velocity more than 2.8, now those patients have at least an intermediate risk of developing pulmonary arterial hypertension, and those are the patients that need to go for a right heart cath for a possible diagnosis. But then we need to look on other additional signings of echographic signs for suggesting of pulmonary hypertension, because even if the number is low and the patients have secondary signs of pulmonary hypertension, we just need to do further workup and possibly a right heart cath. And those signs are in the ventricles, the size of the right ventricle. Remember, the right ventricle is a small structure compared with the left ventricle. So when the diameter increase and the ratio of that diameter with the left ventricle diameter is more than 1, then we start to think that it's a real patient with real pulmonary hypertension. Flattening of the interventricular septum, the TAPSE, which is the the movement of the tricuspid valve between systole and diastole also is a very important factor that we look when we analyze echocardiogram. There are few factors or parameters when we look at the pulmonary artery or when we look at the IVC or the right atrium. For example, if the right atrium is extremely large, more than 18 centimeters, or the IVC filter or IVC vein, the inferior venous cava, is dilated more than 21 or doesn't collapse with the breathing, we think that patient can have a reality of pulmonary arterial hypertension. So this is what I was doing, even if the patient has a normal estimated pulmonary pressure with a tricuspid regurgitation velocity normal, but if they have the presence of other signs of pulmonary hypertension and the presence of risk factors associated to pulmonary hypertension, we need to go for a right heart cath. So for example, a patient with scleroderma who comes with me, even with a normal estimated pressure, but the right ventricle is dilated, we have an IVC that is dilated, that's a patient that we probably need to think on a right heart cath, which before we were not doing, and we were just following up with echocardiograms. Now, pulmonary hypertension used to be a rare disease. An orphan disease, not anymore. It still is rare, but the number and the incidence and the prevalence are going up as we speak. It used to be 10 or 20 per 1 million of population. Right now, the statistics are about 50. New data suggests that could be between 80 and 100 patients for 1 million. Again, it's a rare disease, but it's not an orphan disease anymore. What is more important is the huge cost to any healthcare system. Counts for 200,000 hospitalizations in the United States every year. And the number of patients living with the disease has been growing exponentially since the initial studies back in the early 2000s. A little topic about pulmonary embolism and chronic thromboembolic disease. If we account that in the United States there are 250,000 cases of pulmonary embolism every year, and out of them about 3 to 4% might develop pulmonary hypertension, then you guys can do the numbers. And these are a population that we are not screening and we are not diagnosing still as we should be doing with this condition. Now, out of the patients who have pulmonary arterial hypertension, when it's associated with other conditions, now is the big majority, 51%. Idiopathic, or those we are not able to find the cause, is only 47%. Out of those patients with associated pulmonary hypertension, the big majority is associated to connective tissue disease, and out of those, scleroderma is a big one. We are trying to do a huge effort to make aware all our partners on rheumatology, primary care, cardiology, that patients with scleroderma needs to be screened for pulmonary arterial hypertension. Then the other causes are congenital heart disease, portal hypertension, and drug toxins as being the more prevalent besides the connective tissue disease. The progression of pulmonary arterial hypertension is the same that we have known forever. That the right ventricle is the leading cause of morbidity and mortality on the patients with pulmonary hypertension. My patients don't die from hypoxia, they don't die from respiratory failure, they die from right ventricular failure and right ventricle related complications. So a normal ventricle, the right ventricle, you guys can see here the anatomic conformation of that normal right ventricle and the interaction with the left ventricle. Once the pulmonary vascular resistance starts to go up, because all those changes that we talk about, the right ventricle is able to coupling with that resistance, what we call coupling, or able to compensate. First, hypertrophy, then the anatomic conformation and geographic conformation change to be able to maintain this cardiac output, this cardiac index through the process of the disease. But as long as the pulmonary vascular resistance continues to increase, that right ventricle is going to start to not be able to coupling and start a decompensating, eccentric decompensating, where the size of the ventricle is out of proportion. The diameter of the chamber is out of proportion for the capacity of contractility, and that cardiac output starts to go down. At this point, the mean pulmonary pressure might actually go down or plateau, but that doesn't mean that the condition is getting better. It's actually opposite. The PVR continues to go up, but the right ventricle is not able to flow forward, so the mean pulmonary pressure starts to decrease. And this is when the patients present with signs of right heart failure. And I have to say, still up to this date, 25 years later, we still diagnose patients on functional class 3 and functional class 4. A big majority of these patients are in functional class 3, kind of on the phases of decompensation. So there is a delay, that is an average of 2 years since the presentation of symptoms to the moment of diagnosis of pulmonary hypertension. Even with all the efforts of awareness we are doing, still there is a huge delay on the diagnosis of pulmonary hypertension. I want to touch base this in a little bit, but we are trying to change the design of our trials. The disease has been changed, and what we are trying to do now, initially before 2015, all the studies were only focused on the primary endpoint of 6-minute walk test. Now we try to do composite endpoints, that I'm going to talk a little bit more about this later, but try to come up with a better explanation why the patients do this decompensation, and in reality, those endpoints of morbidity and mortality should be the ones assessed on the studies that we are trying to do. But traditionally, the goals of therapy always were single variables: functional class improvement, 6-minute walk more than 400 meters. If the patient was able to achieve this, we were happy, and we continued the therapies on the same therapies on the patients. Now, there is a huge push to look at the risk that the patient is of mortality at 1 year. So we are just starting to do what our cardiologists did with the Framingham scales and classification 50 years ago, or more than 50 years ago. We are just starting to do this with our patients on pulmonary hypertension. We learned that a single variable cannot be representative for the risk that these patients were having for morbidity and mortality due to pulmonary hypertension. For example, like when I go to the meeting, I tell them, my patients, I cannot follow many times 6-minute walk. Why? Because I live in Florida. My population is in the 7th and the 8th decade of life. Many of them have knee surgeries, knee replaced, or they need a hip to be replaced. 6-minute walk on these patients is not reliable. Many of them are in different medications, diuretics, and other, or they are obese. So BNP alone cannot be the reflection of what the risk of this patient is having. So after we understood that, the European Society came with this classification of risk, and we classify as a low, intermediate, or high risk, depending on the variables you guys see here. But what I want to point here is we are trying to see the patient as a global component, like a holistic vision of these patients, where clinical features play a very important role. Exercise features, including cardiopulmonary exercise tests, can give us an amazing information about these patients. Biomarkers, findings on the echocardiograms. Now is new on these new guidelines, cardiac MRI, because we have better evidence that these findings on the cardiac MRI are as sensitive as the echocardiogram to predict outcomes on pulmonary arterial hypertension and hemodynamics. So we are using invasive testing, lab working, ancillary testing, and clinical findings to predict what risk of these patients might be. And depending on this risk is where we are going to do the therapeutic for them. That risk came from 3 large registries that have been done, 4 registries that have been done on the last 10 years. The first one is the French registry, a little bit more than 1,000 patients. What they did basically was define a low risk status on low risk, 4 low risk factors: functional class 1 and 2, 6-minute walk more than 440, right atrial pressure less than 8, and a cardiac index that is normal. And when they assess the survival over time, or the mortality, they found when the patients have 4 of those low risk, the survival at 3 years was 97%. And you guys can see here how that survival dramatically decreased if those low risk numbers start to go down. The second registry is the comparative registry that was done in Germany mainly, and some of the other Eastern European countries. They define as a low risk with all these invasive and non-invasive parameters, intermediate risk and high risk, and they give a score between 1 to 3 depending on the variable. And at the end, the summatory and the average give you a risk stratification for those patients. And they basically saw the same. And when they were at the baseline, if the patient had high risk, the mortality at 1 year was 20%. No society, no specialty accept this degree of mortality on any condition. What was more important was in the next follow-up of those patients, if the patients continued to be in high risk, the mortality actually went up, kind of demonstrating the necessity to really bring these patients early to follow up, because we need to move them towards low risk on their disease progression. The Swedish registry was very similar to the French. Few low risk factors. They added 1 to 3 points and they calculated the risk, basically showed the same. High risk, less than 40% mortality at 5 years. These registry is a little bit lower in terms of number, but they basically demonstrated that patients with high risk die a lot and patients with low risk have a much better survival. And they also demonstrated that those patients who were able to move toward low risk, the survival improved to more than 90%. And those who actually worsened to intermediate risk or high risk, the survival decreased to 43%. That's an awful survival after 5 years for those patients who are progressing. They also demonstrated that from baseline to follow up, regardless of therapy, only few patients are able to move towards low risk category. On the French registry, only 22-23%. On the Compara, only 10% and less than 7% on the SPAR. So we have learned that even on therapy, the amount of patients that we are moving towards low risk is very low, and we need to do something extra. This is a little bit busy slide just to demonstrate that the American School of Pulmonary Arterial Hypertension tried to do a different scale. It's called the REVEAL registry. And the REVEAL tool for risk stratification is a little bit more cumbersome because it includes PFTs. But I have to say, this is the only registry that has been validated with a subsequent study to predict the risk of mortality, and basically show the same. High-risk patients, survival less than 50% at 1 year, and at 5 years, low risk is close or more than 90% survival at 5 years. And when I say 5 years, is because this is the follow-up that we have so far, but soon they're going to be releasing more data at 8 years. Basically, from the European societies and the American schools, we have the same. We need to classify the patient in a low, intermediate, or high risk, regardless of whatever scale we want to use. But when we look for the key of therapies, or goal of therapies, we move from a single variable to, is my patient low risk or no? So we don't want to accept anyone else that is no low risk, and the current recommendation for therapy are based on this dilemma. Just to touch base a little bit about the current pathways of the disease, still the three main that we learn in medical school are applied. The endothelin pathway. Endothelin is the most potent vasoconstrictor in our body. Two main receptors, endothelin A and B, and we have medications that will block this vasoconstriction, selective endothelin receptor antagonist or dual receptor antagonist. The nitric oxide pathway. Nitric oxide is one of the most potent vasodilators, is present pretty much in all our tissues. And we have two types of medications on this pathway. We have the well-known phosphodiesterase inhibitors, sildenafil and tadalafil, that need the presence of nitric oxide to be able to act because they inhibit the metabolism of the cyclic GMP. And we have a newer, and I say newer because it's been about 6 years in the market, maybe 7 years, and is the soluble guanylase cyclase stimulator. this type of medications doesn't require the presence of nitric oxide to produce, to make the conversion from GTP to cyclic GMP, which is the vasodilator on this cascade. And I'm saying that doesn't require the presence of nitric oxide as an important topic because we have learned that especially on those patients with secondary pulmonary arterial hypertension or related to the conditions, those patients over time become nitric oxide deficient. So it seems like the therapies with phosphodiesterase inhibitors start to wane the effect after several years of therapy. And that's why I'm going to talk about this later. The introduction of these medications might be a good option for therapeutics. And then we have the prostacyclin. Prostacyclin is the most potent vasodilator in our body. We have the traditional prostacyclin I2 analogs, and we have a little bit newer medication that is a non-prostanoid selective IP receptor agonist that had a good evidence changing outcome for these patients. This has been the natural history of evolution on therapeutics in pulmonary hypertension. We went from epoprostenol, the prostacyclin, the traditional prostacyclin back in 1995, to have this number of compounds by 2015. We have not approved anything new since 2015, but again, something is coming in the pipeline really soon. But with this, we were able to change the natural history of pulmonary arterial hypertension. And the recommendation right now is based on a very large and very well done prospective study, the Ambition trial, is start these patients on a combination of therapy. And the study was based on a endothelin receptor antagonist and a phosphodiesterase inhibitor. So the recommendation now is for those patients with intermediate risk or low risk, most of them, we need to start 2 medications up front. That period of time where we will start sildenafil and forget about the patient, that needs to be gone. We need to start 2 medications up front. If the patient is high risk, we need to do combination up front, but we need to include either IV or subcutaneous prostanoid because the high risk mortality is something that we don't tolerate anymore. Very few patients will go into monotherapy. Again, usually those patients who are vasodilator responders on the cath. And the problem is with these patients, only 7 to 9% of the patients are vasodilator responders. Out of them, only 50% are going to remain calcium channel blocker responders after 1 year. But still it happens. But those are the patients that we need to continue monitoring to make sure that monotherapy is the appropriate therapy for them. So the recommendations from the European Society back in 2018 was on treatment-naive patients with PAH confirmed better in an expertise center who are vasoreactive is prescribed calcium channel blockers with high doses. If they are not vasoreactive, we need to do the risk stratification, and if they are intermediate risk, initial oral combination. If it's high risk, combination including systemic prostacyclin. As I said, the oral combination came from this study and now has a recommendation 1B. The follow-up therapy recommendation is we need to bring these patients every 3 to 6 months. We actually have data that we do a very poor job trying to guess the risk stratification of these patients. Just a gustat guess, only 12% of those patients, when we try to assess a risk without using a tool, is adequately put on the risk stratification. Very low capabilities to guess the risk of the patient. So we need to bring them every 3 to 6 months to do this risk stratification. If the patient at that point was able to be moved or stay in the low risk, we should continue the therapeutics that we were doing. But if the patient, on the other hand, remained on intermediate risk or moved to high risk, we need to do triple sequential combination. So we need to add the third pathway and again, continue following them for 3 to 6 months. If that patient continued to be intermediate risk or high risk, we need to optimize that therapy and start to think to call our colleagues of lung transplantation because it's probably the only option that is going to be left for them. On the new guidelines proposed by our European Society, actually they added something that if the patient have other comorbidities, cardiopulmonary comorbidities, they need to be careful treated. And this comes because on that ambition trial that I mentioned, they were doing the study at the beginning with all comers, but already into the study, they did a safety analysis, and they found out that the patients with more than 3 cardiovascular risk factors, including hypertension, smoking, obesity, hypercholesterolemia, or diabetes, those patients had a high incidence of adverse events. And it seems like those patients, the concept is that they have a hidden left heart disease that is not quite evident, and only when you vasodilate them with pulmonary vasodilators is when they become symptomatic. So that's why they're asking now to assess those patients for those comorbidities. If they don't have those comorbidities, we go ahead and treat, as I just mentioned. But if they have these cardiopulmonary comorbidities, they probably are advocating to do initial monotherapy to see response, and then subsequently start to add medications to try to prevent that decompensation of that hidden left heart disease. But again, regular follow-up, bringing them every 3 to 6 months. Otherwise, the recommendations continue being the same. These are the recommendations from the REVEAL registry, and the American groups is basically the same. The only thing that is a little bit different is done with the REVEAL registry, and the subsequent follow-up, they also bring the topic of palliative care. On those patients who the risk stratification after further follow-up continue to be intermediate risk, besides therapy, besides optimizing therapy, or adding the third agent, we need to start thinking in transplant, and we need to start to think in palliative care, because there is data out there that when we involve palliative care from the beginning to discussions of goal of care, the quality of life of these patients actually improve. And they also mention here that we need to do a big push on investigational trials that, as I mentioned before, there is a lot of there. The big picture is, even with dual therapy up front, we are not doing a great impact. We know now that on further follow-up, the big majority of these patients, there is not really much change on the PVR after 6 months on double oral therapy. And many of these patients are not moving towards the low risk categories. The problem is, no study has been done to document that triple therapy up front is better than dual therapy either. But we know that these patients need to be added subsequently all the other pathways of therapy. For example, these patients, when they were started on monotherapy, these were the baseline of 4 low risk criteria. These are based on the French registry patients. Sometimes when they are on triple therapy, look at the presence, probably these patients were not, none of them was low risk. But in further follow-up, when the first follow-up was assessed, usually between 3 to 6 months on that registry, only the patients on monotherapy, only 8% were able to be moved to low risk. Dual therapy, only 14% of those patients were able to be moved towards low risk, which kind of documents that we need to do more, and maybe triple therapy up front might be some of the answers. But again, we don't know which one of the additional therapies, and basically we don't have any follow-up data besides that. Now, few of the new kids on the block. As I said, there is a lot of data out there that if you have patients who started to continue to be on intermediate risk, actually the recommendation now on further follow-ups, if the patient doesn't move towards the low risk, the idea to switch those patients from PDE5 inhibitors to a soluble guanylate cyclase stimulator is very reasonable. And that was based on a couple of studies. This one was an open label, 24 weeks, and basically they showed that when we did the switch, the patients were able to walk more, and the patient's BNP actually decreased dramatically. This open label study led to the randomized study. The big difference was the clinical endpoint, and it was the clinical improvement after 24 weeks of the change, defined as the absence of clinical worsening, improvement of 2 out of 3 variables, including 6-minute walk, functional class, and BNP, and basically showed that a large percentage of those patients on the soluble guanylate cyclase stimulator were able to reach this endpoint, were able to walk more, were able to decrease substantially the BNP, and survival was a tendency towards survival, but everyone knows that the study was not powered to that. So one of the recommendations is if the patient continued to be intermediate risk, we need to switch from PD5 inhibitor to the soluble guanylate cyclase stimulator and try to do the switch soon on the process of the disease, because it seems like the earlier we do, the more impact we have on those outcomes. Now, this is a new player. Everyone is very excited about it. We were able to participate on this study. The compound is called sotatercept. Is basically the bone morphogenic proteins which are associated to downgrade the pSMAD change, which is associated with proliferation. Remember, this is one of the main genes that is mutated. The BMPR2 receptor gene is one of the main genes associated to familial or hereditary pulmonary hypertension. But these BMPs are basically associated with increased proliferation through activins and growth proliferation factors. What this medication does is binds that those factors associated with that proliferation, so kind of restoring the balance towards decrease of the proliferation. And the study was done called Pulsar. The initial study, this is the phase 2 study. They were randomized to this molecule against placebo or against 2 doses. And basically they showed that the response on the vascular resistance was dramatic on the higher dose of the sotatercept. And at the same time, there was an improvement on the 6-minute walk functional class. And the phase 3 study, which we were able to participate, enrollment is closed, and they are in the process to do the analysis, is ongoing. They're hoping to finalize the results by the end of the year, but it seems like the results in terms of pulmonary vascular resistance is dramatic. Basically, it's the first time we have a non-vasodilator, but a medication that primarily will affect the primary process of proliferation. Now, a couple of minutes on ILD-PH. This is a new change on the last year or two. Is this really a new entity, or is something that has been there for a while and we just didn't realize? But what we know is pulmonary hypertension is very frequent in chronic lung disease. On COPD can be as high as 50% of those patients can develop pulmonary hypertension. On pulmonary fibrosis, up to 86 of those patients can develop pulmonary hypertension, I should say. And sarcoidosis, the number is a little bit similar. Again, with this group of sarcoidosis, we don't really know if it is the primary process of the granulomas or the ILD. Well, basically what we have shown is when those patients have associated pulmonary hypertension, the survival is dramatically lower. Those patients die more. Those patients have a more limited functional capacity, more limited exercise capacity. They require more oxygen, and the mortality rate is also elevated. Chronic hypersensitivity showed the same. The patients have pulmonary hypertension, the mortality, the survival is decreased. The number of exacerbations in patients with pulmonary fibrosis is increased when there is a pulmonary hypertension associated. And that number of exacerbations is directly correlated with survival. And that's what's something that gives me the full of pride, because we were able to participate on this study. We showed that when we treat patients with pulmonary hypertension related to interstitial lung disease with inhaled prostacyclin, the patients were able to walk more. There was an improvement on functional class. There was an improvement on BNP, decrease on the BNP. And not only that, for the first time, this study suggested that the pulmonary function test, more particularly the forced vital capacity on the patients who were treated with prostacyclin, improve when compared with the placebo. It's the first study that showed some degree of improvement on PFTs when patients with ILD, PF, IPF were treated with prostacyclins. That led to a study that we are doing also under the guidance of Dr. Bandi to see if when we treat patients with pulmonary fibrosis without pulmonary hypertension are able to replicate these findings and improving outcomes on those patients without pulmonary hypertension. So now, as I'm going back to this slide, this is how the future looks, but this is something that brings hope to us because, again, we are changing the natural history of this disease. More compounds are coming. Serotonin agents are being studied as we speak on the latest phase of the studies, and it seems they're going to have good results. TKRs are also being studied, growth factors, calcium channel activators. There is a bunch of medications that are in the latest phase of research that it seems are going to be able to positively impact the outcomes on these patients with pulmonary arterial hypertension. So the big message that I wanted to transmit today is we have changed the definition of pulmonary hypertension. We are going to have a more number of patients on the echocardiogram. Don't look only on the estimated pressures, look at the morphology and capacity of working of that right ventricle to define pulmonary hypertension. And when we decide to treat these patients after confirming the diagnosis, we need to start more than one therapy up front and follow up these patients regularly every 3 to 6 months, because that is what is changing the outcome of these patients. So I'm going to stop there and open to questions.
Well, thank you, Dr. Restrepo. It sounds like it was so clear that no one really has any questions, so we appreciate your time and time teaching us many questions. I think we can end before the expected time. Thank you, everyone.
Thank you.
Thank you, Dr. Restrepo.